My name is Zach Jarou, and I'm a fourth-year resident at Denver Health Medical Center doing my training in emergency medicine, and today I'm going to be giving a talk called From Data to Wisdom, the Future of Digital Health. One of my attendings, Dr. Jason Hokus, once told me that the most important thing that physicians do is make decisions, and that we can't make decisions without having accurate data. But what is data? Data is what we see, it's what we smell, it's what we hear, it's what we feel. It's an EKG, it's a chest x-ray, it's a BMP troponin in chemistry, it's in a petri dish. It's on your wrist, and it's the building blocks of life itself. American poet T.S. Eliot once said, "Where is the wisdom we have lost in knowledge? And where is the knowledge we have lost in information?" And if you're lost about all these terms, a data scientist by the name of Ackoff came up with a way to contextualize all of them. So this is the DIKW pyramid. As you can see, there's a proposed hierarchy to all these terms, and there's layers of understanding as we move up the pyramid. So data is raw, it's sensed, it's the product of our observations. Without any context, data in itself is meaningless. Information is data with a context. It helps us make decisions. By the combined information that we have, that contributes to our knowledge. And knowledge is the way that we use our collective experience, past experiences, to make decisions. And the pinnacle of this pyramid is the wisdom. And wisdom allows us to apply our knowledge and our skill sets to new problems that we've never encountered before. Vision allows us to see beyond the horizon and tell where things are going next. The chairman of our department, Dr. Richard Zane, also passed along some sage wisdom to me throughout my training to spend 3 more minutes, ask 2 more questions, and order 1 less test. And what he was really trying to get at was that we really need the context when we're treating patients in the emergency department so that we can take our data and turn it into information. So I want to take a little bit of time to talk about how humans have recorded information throughout history. First developed written languages came about in 3100 BC in ancient Mesopotamia. You can see here some ancient Egyptian writings. The Sumerians were also developing written languages. And the first written medical record was actually written in 1600 BC about the surgical endeavors of some Egyptian surgeons. So leaving ancient Mesopotamia and the Egyptians and Sumerians, by the 17th century, there were physicians and they're still keeping records. However, these were mostly case reports of how a patient presented, what was done, and what the outcome of their treatment was. Now, with the rise of laboratory medicine, radiology, and sort of the complexity that developed within medicine, we needed to develop a more structured way to do that, which is sort of the traditional HPI that you might know today that's organized by problem. Now, in terms of who generated these records, initially this was done by large pools of transcriptionists, listening to medical dictations from physicians, and it wasn't really available at the bedside and wasn't really driving patient care. We also developed T-sheets, and I was fortunate enough to use paper records as recently as 2 years ago at my training site. Electronic health records were first developed initially in the 1960s, and early informaticians had a lot of hope that these would really be able to improve patient safety and really be used as a bedside tool and help drive clinical decision making. Unfortunately, despite these thoughts in the early 1960s, most computers in early hospitals were used for administrative and billing purposes. In 1991, the Institute of Medicine put out a report about the 10 goals that an electronic health system should have, including a problem list with the status of each problem, systematic measurements and recordings of the health status of each of these issues and the functional level of the patient. The logical basis that was used to go into making all the diagnosis and all the conclusions that are reached. The ability to link the electronic health record with records from outside sources. To be able to comprehensively address data confidentiality and to allow the record to be available to all individuals in the hospital that are caring for a patient and to be accessed by multiple people at the same time. Additionally, they knew that we should have retrieval mechanisms that are tailored based on the setting that you're in. If I'm in the emergency department, I need a different set of information than someone needs in the clinic or in an inpatient setting. They need to be linked to knowledge sources to really help drive decision-making for a rare diagnosis or for common diagnoses of which there's a locally accepted standard of practice. They should collect information in a structured data instead of free text so that you can use it to query and leverage the information that's in with your health system. They should help manage the quality and cost of care, and they should be flexible and expandable and really tailored to every single specialty in the hospital. So despite these early goals of the informaticians in the 1960s and this 12-step process that was outlined by the Institute of Medicine in 1991, it really wasn't until 2009 and the High-Tech Act that really we began to see the wide adoption of electronic health records. And today, in the hospital usage of electronic health records, Epic, Cerner, and Meditech are leading the way. And in the outpatient setting, you can see that Epic is also leading here as well. So, we finally see the adoption of electronic health records, but are they really doing what we need them to? Are they really addressing those 12 points that the Institute of Medicine identified in 1991? And I think the answer is no. So we all know that the electronic health record isn't perfect. And in fact, we've had to develop an entire new industry in order to input information into the electronic health record. By the year 2020, there's going to be 100,000 scribes in the United States, and it's going to be a $1 billion industry with one scribe for every 9 physicians in the United States. So while scribes are really helpful so that physicians can spend more time at the bedside and more time thinking about the clinical decisions that they're making, I think that they're really patching a problem that needs to be addressed. And I really question whether the success of scribes has dampened the enthusiasm for electronic health record vendors to create software that's actually usable and functional for physicians. Other innovations that have taken place in terms of the way that we capture data. So we've got voice recognition tools. We've got tools like Epic Haiku that allow us to take pictures and insert directly into the medical record. And in the future, you could imagine that maybe your physician is wearing a pair of Google Glasses, seeing you in real time. A virtual scribe or natural language processing could be documenting everything that's being done in the record. And you could order labs, you could see vitals. It would be aware of where you're at in the department and show you the information that you need in real time to treat the patient in front of you. Now that we've talked about the way that we can turn data into information and information into knowledge, and let's talk a little bit about the way that we transmit information. So these are homing pigeons, and for more than 3,000 years, humans have used them to send messages to one another. They can find their way over long distances of thousands of miles. They can fly a mile per hour. And they're actually the first health information exchange. So in the late 1800s, there's some letters to the editor in JAMA of a country physician who tells his story about using these carrier pigeons in order to treat his patients. So what he would do is, as he was making his rounds in the countryside, he would take a pigeon from his home, his practice, and he'd leave a pigeon at each site. And he'd leave instructions with the patient to say, I'd like to know how you're feeling in the morning. What has your temperature been? How many bowel movements have you had? And in the morning, the patient would release the pigeon, it would fly back to the physician, and he'd have an update on the way that his patient had been doing. Eventually, carrier pigeons have been replaced by other technologies, and now we live in a very wired world. So thanks to the development of this wired and interconnected world, we started with the telephone, but we haven't really moved past the fax machine, unfortunately, in a lot of clinical settings. So as you know, this is not a new technology. It's been around for a long time, and unfortunately, it's still a staple in modern medicine, if you can believe that. So in 1924, The first ever fax image was sent, but in 1964 it was widely adopted, and it's been in the medical setting ever since. But in today's hyperconnected world, there's no reason that we should be using fax machines. For anyone who's worked in a clinical setting, they know the joy of requesting medical records. First, you have to go find the records form. Then you have to fill it out. You've got to get the patient to sign it. You've got to find the fax number of where you're sending it to. You've probably got to call someone at the accepting hospital to say, hey, I'm sending you a fax. I need my records quickly. Can you please be on the lookout for it? Then you have to figure out how to work your darn fax machine. You have to make sure that it actually went through. And then you get to wait. And in an emergency department, that's not very good for patient care. So we do have some ways that we can address these problems. We've got things called health information exchanges. The best known health information exchange is Epic's Care Everywhere, and as you saw in the previous slides, they've got a huge share of the market. So 50% of all health information exchange occurs using Epic Care Everywhere. The same HITECH Act that gave money for hospitals to implement electronic health records also created grants to create regional health information organizations, and these have been really valuable tools to allow physicians to access information outside of their system without having to go through all the cumbersome efforts of sending faxes. Health information exchanges also allow us to monitor other things like use of controlled substances. And in the future, they'll allow us to report quality measures so that we can document our adherence to principles and we can show that physicians are providing high quality care. And this will be especially important in the future as the macro penalties kick in that will determine physician reimbursement by adherence to these quality measures. Other ways that health information exchange can be useful are in the pre-hospital setting. So right now, you've got an ambulance that picks up a patient. They have no idea what the patient's medical history might be, and they call ahead to the emergency department and they say, I've got such and such a person with these vital signs. Now imagine a world where the paramedics would be able to pull up the patient in the electronic health record. They would be able to see all of their diagnoses. They'd be able to see recent admissions. And they'd be able to pre-register a patient at the hospital that they're arriving to, so the moment that they hit the door, a physician can start entering orders, and also the physician would be able to know how far away is this ambulance. We've all gotten a call that said we'll be there in 5 minutes, and you're standing at the head of the bed for 15 wondering where this person is at. And there's actually tools right now that can do this, where you can pre-register a patient, take pictures from the scene, send pictures of EKGs, and have GPS-based time of arrivals that are visible in the emergency department so you know who's coming and when they'll be there. Exchanging information isn't just between healthcare providers, though. Patients play an important role in this. And tools like Epic MyChart have allowed patients to really take ownership of their health information. They allow patients to see notes that have been written about them, their discharge summaries, their lab results, their imaging, and their medications. These are really important tools to allow patients to take ownership of their health information and accept some responsibility for their care that they're receiving. There's also innovative tools being developed for patients that are in the inpatient setting, where you're not just seeing the notes from what's already happened, you're seeing in real time what's happening to me. What's my schedule for the day? When do I get to eat? When are they going to round on me? When do I get my imaging study done? What are my diagnoses? What does it mean? What are the medications I'm getting while I'm here in the hospital? What are the risks? What are the benefits? And these are going to be really, really important tools to help patients take an active role in their care, and health information exchange is going to facilitate that. So we've talked about the recording of data, the interpretation of data, how do we collect it? But now, one of the other things that those early informaticians had in mind with the development of electronic health records was how can we use the electronic health record to help us make decisions at the bedside? So, for anyone that's practiced medicine in modern times, you know that there's a plethora of clinical decision tools that are available that help us risk stratify patients and ensure that they're getting the best treatment possible. Things like PERC, MINDS, HEART, Nexus. So we live in this world of pathways and clinical decision tools. Now, wouldn't it be incredible if the information that's already available in the health record could automatically be input and can help us calculate these risks and help us make decisions at the bedside. So in terms of clinical decision support, we've all seen these annoying pop-up boxes that interrupt our workflow and tell us that we're doing everything wrong and lead us into a subsequent series of clicks to do the very simple task that we intended to do in the first place. Some institutions have also developed pathways that are integrated right into the electronic health record that you can click on the pathway and immediately input orders to draw for a patient. Things like order sets are examples of clinical decision support. In the world of OB, getting to that issue of the EHR needing to be adopted to the environment that you're in and the specialty that you're in, you can have tools that show you exactly the information that you need to know about your pregnant patient. Templated notes are an example of clinical decision support. And we have data that shows that clinical decision support can actually decrease utilization of health resources and maintain quality. So getting back to that annoying sort of pop-up message, we know that for clinical decision support to be effective, we need for it to really be helpful to the physician and for there to be a great user experience. So speed is everything. And if the decision support requires leaving the EHR, it's too many clicks away, it's not going to be used. Clinical decision support needs to anticipate your needs and deliver in real time. So as if a patient's been triaged as having chest pain or shortness of breath, or as I'm writing my history of present illness, natural language processing can really sort of see where the story is going and anticipate my needs. That would be very, very effective. It's got to fit into your current workflow, and little things can make a big, big difference. Things like in the emergency department, for instance, we've got every medication we want there is going to be stat once now. And if you have your EHR set up to do that, it's a lot less clicks for the physician so they can spend time doing important things, being at the bedside and caring for patients and making decisions. And recognize that physicians will strongly resist stopping. So a pop-up that just tells you what you're doing is wrong is not an effective tool. However, a tool that maybe suggests that you pivot your behavior or take an alternative path forward has been shown to be more effective. Simple interventions work best. So we don't need to radically overhaul the EHR all at once, but we can make a series of small tweaks that really make it easier for the physician and to have their buy-in and just to continue to iterate upon what's already working. Only ask for additional information when you need it, monitor your impact, get feedback, and respond. And manage and maintain your systems. So in terms of clinical decision support in the future, you could also imagine that artificial intelligence tools like IBM's Watson might really be able to help us leverage big data and make decisions about our patients and really aid us in the diagnosis and treatment of diseases, especially rare ones. So where are we going and how are we getting there? That's a quote from Kevin McVaney, and it'll be in my mind for the rest of my career. So the future is digital health. And what is digital health? It's all about convergence. It's wearables, it's wireless, it's sensors and social networks, it's text messaging and telemedicine, it's genomics and gamification, it's personalized and precise, it's here now, and it's going to play an ever more important role in the future. So that was sort of a broad explanation of what digital health is. I think in terms of some things that people might be able to relate to now are this world of wearables that we're in right now. Everyone has a Fitbit or an Apple Watch or something that's recording and monitoring us in real time. It's the pumps in the hospital that are wirelessly transmitting the ins and outs of a patient in real time to the electronic health record. It's a pacemaker that can wirelessly transmit the heart rhythm that a patient's been in. It's an insulin pump that keeps a very accurate log of the amount of insulin being delivered in a patient's blood glucose in real time. But when we have an Internet of Things and the world around us is all connected to the Internet, especially our healthcare things, we have to be worried about security risks. So what is at risk? So we just mentioned that in the future, if I've got a pacemaker or defibrillator that can wirelessly transmit information, that means it can also wirelessly receive information. And you could imagine the danger that could happen if a hacker were able to activate your defibrillator at any point in time, put you into a life-threatening heart rhythm. You could imagine the danger if an insulin pump were suddenly set to full drive and someone gets hypoglycemic and gets in a car accident. You can imagine the danger that could happen if someone on an infusion of a vasoactive medication in an ICU, that infusion rate were to suddenly change. And this is a big issue as we develop this Internet of Healthcare things. And luckily we've got very smart people like my friend Christian Demeth, who wrote this article in EM Resident Magazine, who are dedicating their entire career to this. So we've talked about some of the cool technologies that can be coming to really help taper and design care and tailor it to exactly what the patient needs, and how having access to all of this remote data can help physicians make decisions. But technology is not inherently good or evil, and there are risks associated with it, as we just discussed. And as we've talked about that DIKW pyramid, and we've talked about the way that we collect data, the way that we assign meaning to it, the way that using clinical decision support systems are a way for us to apply knowledge. Now we're sort of at that top part of the pyramid where we're talking about wisdom. And so we've got some important decisions that we need to make in terms of how we implement these new technologies in the future. So one example is the development of fertilizer. So the Haber-Bosch process is a nitrogen fixation process that allowed us to revolutionize agriculture and to feed the masses. But at the same time, it also has led to toxic runoff from fields and anoxic water areas, killing of wildlife, and that same process was also used for the development of explosives. Another example of technology gone awry. So, similar to the way that we wanted to increase our agricultural output, we also want to increase the production of livestock. And in 1948, there was a big contest that was created to create the biggest breasted chicken. And chickens are now sort of selectively, bred, and they're raised in conditions that allow a tremendous amount of protein and food in a very short period of time. But that's been done at the expense of the process in which it's done. And so now you've got a chicken in every pot and an antibiotic-resistant gene in every bacteria that's infecting those birds who are kept in very confined spaces. So while the future of digital health is very promising, we can't allow technology to devalue the physician-patient relationship. Patients need your warmth, your empathy, and if we fail to know the people that are behind the data points that we're seeing, we're no better than a computer. And I know that I, for one, don't want to compete with IBM Watson. So in closing, this is another quote from one of my attendings here at Denver Health. Patients will tell you what they think you're prepared to hear. And while all these digital health technologies are very exciting, what we ultimately need is a warm, empathetic person at the bedside to listen to and care for patients. Thank you very much.